See my slides. Perfect. So thank you so much, Paul, and everyone for the invitation. It's really a delight to be able to talk about some of our work in genetic communication. Hopefully I will have a chance to see you all in person not too long from now. So what I'd like to do today in the talk is introduce the general area of genetic communication, and I'm focusing today particularly on genetic and genomic literacy. So I'll describe some of our findings from a scoping review of this literature, a few of examples from my work and in collaborations with others, and then conclude with clinical translational project that we're working on now as a current research direction. And my goal is to save about 10 minutes or so for questions at the end. So this is my general area of research. I've now worked in genetic communication for 15 years, which is hard to believe. And I think of it as how you take all of this information that's being generated by technologies in genetics and genomics and convey it to people in ways that are understandable and also useful so that they can apply it. Most of my work has been with patients and the general public, although increasingly also working with primary care providers as another audience for genetic communication. So just a little bit about me, because it really informs how I think about my own work. I actually started in molecular and cellular biology in a Drosophila melanogaster lab, and decided quickly that bench science was not what I wanted to be spending my days doing. So I found public health, and particularly health communication, which allowed me to really focus on some of these interesting, intricate issues in science communication. And I was fortunate enough to be able to work with Rima Rudd, who is really one of the world's experts at this point in health literacy. And she really has informed how I've thought about my work since. How do we communicate with people who have varying levels of knowledge and skills about science and health? And I was actually fortunate enough to be able to unite these two areas of research at the National Human Genome Research Institute in my first faculty position, which was intramural at NHGRI, and allowed me to help create this area of communication of genetic information, which I've carried forward then now for 15 years or so in my work at the University of Utah. As Paul mentioned, we are a very genetics-focused cancer institute at the Huntsman Cancer Institute, and so it's been a really fruitful place to be able to do this type of work. So I'm sure this audience knows that there is a growing use of genetic and genomic information in cancer prevention and screening, as well as the care of oncology patients. And what's been interesting to me over the last few years, certainly, is the increasing affordability and accessibility of these tests have meant that we are reaching more people than we used to, and different population subgroups. So rather than only white, non-Hispanic, highly educated, and well-insured patients, we're starting to have to grapple with how do we communicate across different population subgroups. And of course, I think primarily about what the effects of varying health literacy is in this type of communication. And together with these increases in reach, we're also having different types of technology, which are bringing new challenges in communication. So we think a lot about communication of uncertain information, my group and many others across the nation. How do we communicate about variants of uncertain significance, which is increasingly done clinically? It is done at Huntsman. How do we communicate about secondary findings? So the types of findings that are not related to the initial indication for sequencing or other testing, but still might be returned to patients. Increasingly, we're thinking about return of ambiguous or indeterminate findings, as well as considering non-actionable results, which have not generally been returned to patients, but we're seeing a real push from patients to get that type of information back if they judge that it has personal utility. So these are all the sort of challenges with communication that my group focuses on. And of course, this increasing information complexity has important implications for clinical care as well as public health. So knowing how to take this uncertain information and use it in clinical management, or more accurately, I guess, not use it in clinical information management if it's not indicated, is an issue that both providers and patients grapple with. Together with increasing levels of confusion we're seeing about results, as well as this issue of communication about uncertain results. We are also seeing, because of limitations in the genetic counseling workforce, increasingly these results are being returned by other types of providers. So whether that's primary care providers or oncologists, people who do not have the specialized types of training in genetics and genomics. And what they report in studies is that they generally feel unprepared to have these types of discussions with patients. And so the premise of my work is really that the successful translation into the clinic of information that is generated by genetic and genomic technologies really depends on the genetic and genomic literacy of patients as well as providers in order to have patient-centered care and improved health outcomes. And I wanted to take a minute just to define what I mean when I say genetic and genomic literacy. And I have to say, I use those two terms a little bit interchangeably because there are many different definitions at this point of what we mean when people say genomic literacy. And in a lot of cases, that's actually used to be fairly synonymous with knowledge. So people use genetic literacy instead of genetic knowledge. But I think about this as somewhat broader. And this is a definition from a working group that I participated in at the National Human Genome Research Institute back in 2012, but it's still a very useful definition. So they defined genomic health literacy in this case as the degree to which individuals have the capacity to obtain, process, and understand basic genetic information and services needed to make appropriate health decisions. So for those of you who are familiar with health literacy and its definitions, this will sound very familiar, but I find this useful because it allows us to think about the types of conceptual knowledge that people need to process information, as well as the types of skills that are needed for accessing genetic information, processing it, interpreting and understanding it, and then using it to make decisions in a clinical setting or for their own care. And so this framework for me really has highlighted a few challenges that you'll see is reflected throughout the studies that I'll present. So we grapple a lot in genetics and genomics with unfamiliar and often abstract concepts. So the idea that people, for example, have two copies of a gene is something that's often unfamiliar. And so the idea that there's a difference between having one risk increasing variant and two is often a concept that they are not familiar with. The difficult, or I should say unfamiliar jargon that comes with genetics and genomics, knowing when to use the jargon, when to define the jargon, and when to substitute the jargon is something I spend a lot of time thinking about. Probabilities, I think, is still a very understudied area. So we know that genetic information comes with a lot of probabilistic information about risk, and we still don't really have a good sense how to convey some of that type of information, particularly to people who have lower levels of numeracy or number-related skills. And finally, we're increasingly facing an issue of information overload. So for a long time, we've been communicating one result at a time. And increasingly, the technology, as well as clinical care, is heading toward communicating multiple types of test results at one time. And so how do we convey that type of information without completely swamping out the cognitive capacity of the patient we're speaking to? So first, I'd like to present some results from a scoping review that I conducted with colleagues at the National Cancer Institute, including Sylvia Cho and Bill Klein. And the rationale behind this particular scoping review was to get a better sense of where the genetic communication literature was a couple of years ago, particularly related to cancer. So the goal of the overall scoping review was to synthesize recently published literature from diverse disciplines, so not only communication, but focused on communication of cancer-related genetic and genomic information to patients and the public. And what I'll present today is one analysis out of this scoping review that looked at to what extent the studies that were identified either assessed or described people's genomic literacy, their health literacy, their numeracy, and their genetic or genomic knowledge. The scoping review itself was a comprehensive search of 6 databases, so Medline, of course, but not all of the literature was in Medline. We also searched the nursing literature, the communication literature, psychology, education, and so forth. The scoping review focused on articles published between January of 2010 and January of 2017. And the rationale for that choice was that there had been a number of large reviews that came out in 2008 and 2009. So we wanted to search the more recent literature after those reviews. But I think more importantly, we wanted to capture what was happening in the communication literature at the time when newer sequencing or next-gen technologies were being introduced into the clinic. So particularly around the time when multi-gene panels and sequencing were being introduced, to what extent did the communication literature reflect that change in technology? I should mention these were all English language papers. They had to have at least some cancer focus, so we were not able to capture many of the interesting papers that did not include a cancer focus. These were all papers focused, at least to some extent, on communication to the public or to patients. So family communication only was not captured, as well as provider-provider communication. And all of the papers had at least some empirical data presented, so we excluded a purely normative analysis. But one of the nice things about this being a scoping review as opposed to a meta-analysis or more systematic review is we were able to capture all study designs. So we included qualitative papers, mixed methods papers, and so forth. This turned out to be a fairly large undertaking, I think more than we realized when we got into it. So after reviewing the 6 databases and removing duplicates, we had more than 9,000 papers to screen the titles and abstracts of. We were able to exclude about 8,000 of those, which still left us with 1,300 papers to review. And in the end, 513 studies met our inclusion and exclusion criteria, which I described on the previous slide. So this was a larger literature even than I realized, having worked in it for a long time. But what was interesting when we looked specifically at to what extent this literature included genetic literacy, health literacy, and numeracy, is that it really did not between 2010 and 2017, or I would say very little. So of the 513 papers on communication of cancer genetic information in this timeframe, only 5 assessed or described genetic or genomic literacy. And we were pretty generous, actually. If they said that term once, we included it. So very few papers assessing genetic or genomic literacy. A little bit more assessing health literacy, so 12 papers, which was 2% of the total sample. And about 21 assessed or described numeracy. There were more that assessed genetic and genomic knowledge, so that was about 18%, but literacy and numeracy itself was really pretty uncommon in this literature. And what I'd like to do is just present a few more specific results, just so you can get a sense of what this literature actually looks like. So these are the 5 papers that focused on genetic or genomic literacy. And as you can see, 3 of them were qualitative. And in general, what this was there was a theme that related to genetic literacy or genetic knowledge. There were only 2 papers that were quantitative. One used the Rapid Estimate of Adult Literacy in Medicine as the genetic literacy measure. This is a word recognition measure created by Lori Irby and Deborah Roeder at Johns Hopkins. And what they were specifically looking at was the relationship between genetic literacy and learning from videotaped genetic counseling sessions, so analog sessions. The other paper used a genetic risk communication measure that was created by that specific team. And they found that genetic literacy was positively related to being able to make decisions about surgery, or at least forming opinions about surgical decisions. So that was the extent, at least at that time. There are more papers that have come out since 2017. So we are actually updating this specific review now. So the health literacy papers, 2 of them again were qualitative, 10 were quantitative. The most common measure, for those of you who are interested in measurement of health literacy, which I feel like I could spend an entire talk about, but we'll mention briefly here. Most commonly, people were using the subjective screener items. So for those of you who know this literature, the items from Lisa Chu, where people are asked to self-report their health literacy skills. 3 papers use the rapid estimate of adult literacy in medicine, which is another word recognition measure. But what was interesting about this literature was there was not much consistency in outcomes that were being examined. So there was examination of associations between health literacy and a wide variety of outcomes. So just a few of them are listed here: knowledge, interpretation, perceived understanding, genetics-related belief, as well as self-efficacy. And my work and others have looked at the association between health literacy and other communication of test results to others. And we saw something similar with numeracy. So these were the 21 papers focused on numeracy. They were all quantitative papers. A variety of different measures of objective and subjective numeracy. So the objective measures are the ones that ask people to do math-related tasks. And subjective measures ask people to self-report their numeracy, both their numeracy ability and in most cases their preferences. So do they prefer to get information in numbers or by words? But again, what we saw was there was a wide variety of associations that were being examined. So people looked at the association between numeracy and a variety of outcomes, just including awareness, genetic-related knowledge and beliefs, recall, perceived understanding, interpretation. Actually, a number of papers looking at willingness to pay for genetic testing, and then surgical intentions. So what we found in this literature is, of course, a few papers assessing genetic literacy, genomic literacy, health literacy, or numeracy in this larger body of literature, which is pretty robust in many ways at this point, looking at communication processes with genetic and genomic information in the context of cancer. But what was interesting to me is that there were few studies examining the associations between any of these constructs and any particular outcome. So there's really not a knowledge base at this point to do something like a meta-analysis, looking at the relationship between health literacy and interpretation, for instance. And what this really suggested to us is the need for both theoretical and empirical work on how these genetic and genomic related domains of knowledge and skills are impacting people's processes and downstream health outcomes. So what I'd like to turn to next is just to describe some of the work of my group in this particular domain. And I'll start with numeracy and then talk about some of our work with health literacy as well. So I'll first present some findings that were generated by an R01 funded by the National Cancer Institute, which examined people's communication preferences for genome sequencing results. And I'll talk about the patient population in a minute. But our goal was to examine factors that influenced communication preferences, as well as to examine communication preferences and how it differed by patient subgroups. And the factors we thought would be important were clinical factors. So things like family history of breast cancer, whether people carried a known mutation in BRCA, 1 or 2, whether they had had prior genetic testing. And just to give away my punchline, the clinical factors were not what were driving communication preferences. We also examined numeracy, ability, and numbers preferences, so preferences for numbers versus words, and how that affected people's preferences for what types of results they would want. This study was from a survey of an existing cohort, which was founded at the Washington University School of Medicine in St. Louis and called the Young Women's Breast Cancer Program cohort. At the time we did this study, they had enrolled more than 2,000, close to 2,300 women who had been diagnosed with breast cancer younger than age 40, which of course suggests possible genetic involvement. There were a lot of advantages for this cohort. For one thing, it was very well clinically characterized. So we knew if people had had testing, we knew that we actually had their records, so we knew exactly what mutation they carried. And we also knew their family history of breast and ovarian cancer, and scored by a certified genetic counselor based on a 3-generation pedigree. In a lot of my survey work, we are often left with sort of, do you have family history of cancer? Yes, no. With this survey, we had the advantage of really knowing the strength of their family history. This is largely a Caucasian cohort. Their mean age at diagnosis with cancer is 35 years. And their mean time since diagnosis at the time they enrolled was 7 years. So it's not necessarily a newly diagnosed cohort. And the data I'll be presenting was from a survey of the whole cohort. We got about a 60% response rate, so just under 1,100 respondents. Just methodologically, we offered people the opportunity to do the survey online, by telephone, or by mail, and most people choose to do the online version. I'll be presenting data from some of the survey domains. We created measures of communication preferences based on our prior qualitative work, a knowledge that I created with collaborators at the National Human Genome Research Institute, looking at knowledge of genome sequencing. We looked at how people prefer to make decisions. We looked at their worry about their genetic risks, as well as worry about cancer recurrence. Since this is a survivor cohort, we looked at recurrence worry. We also looked at whether they sought health information, their health information seeking, what's called present or future orientation. So essentially, are they more focused on risks in the present or risks that may happen to them in the future? The extent to which they place importance on health information or their health information orientation. And then their numeracy, which is a measure created by my colleague, Angie Fagerlin, who is now here at the University of Utah. But she created the measure at Michigan, looking at people's self-reported ability with numeracy, as well as their self-reported preferences. So do they prefer to receive risk information, for example, in numbers or in words? This is just a bit about our respondents. 11% carried a known mutation in the genes BRCA1 or 2. The vast majority that had prior genetic testing, normally for BRCA. About a quarter, 28%, had a strong family history of breast cancer. 15% had had a second primary cancer. Most had biological children and were married or living with a partner. And this was a pretty highly educated cohort, so only 21% had some college or less. And at the time they did the survey, the mean age was 46. So one of the domains on this survey asked them, if your genome were sequenced, to what degree would you be interested in different types of variants that may be generated by genome sequencing? So this question was on a scale from 1 to 7. How interested would you be in receiving results from each of these different types of variants? And we described the different types of variants to them in the survey. But we asked about their interest in variants affecting risk of a preventable or treatable disease, variants affecting medication response, variants affecting carrier status, variants affecting risk of an unpreventable or untreatable disease, variants related to ancestry and physical traits, and variants of uncertain significance, or VUS. So what you're seeing on this slide are just people who said 7. I am very interested in receiving this type of result if my genome is sequenced. And I think the top 2 aren't terribly surprising. We know that people are most interested generally in actionable results. So almost 3/4 were very interested in getting variants that related to their risk of preventable or treatable disease, as well as medication response. Interestingly, 71% were also very interested in carrier status variants. And when we looked at some open-ended data, We think what that's reflecting is that this is still a pretty young cohort. Some of them were reproductive age or had siblings who were reproductive age, and so they were interested in this information. Many fewer were very interested in receiving results for unpreventable or untreatable diseases, the sort of ancestry of physical traits, or VUS. And that's not to say they weren't interested. They were just much more likely to say they were somewhat interested than very interested. So on this slide, what you're seeing are 6 multivariable logistic regression models. So the columns are models reflecting very interested in each of the 6 different types of variants, which I just showed you on the last slide. And the rows are the predictors, the factors that we looked at as predicting interest. And the reason that I'm showing them all on one slide is because, interestingly to me, there were 3 variables that predicted across the different types of genomic information. So people who had higher knowledge about the benefits of genome sequencing were more likely to say they were very interested in receiving each of the 6 different types of possible results. Similarly, people who were or had a high degree of worry about their genetic risks were more likely to say they were very interested in each of the 6 types of results. And the strongest predictor was actually health information orientation. So people who placed strong importance on health information were also more likely to say that they wanted each of these 6 different types of results. We did see some relationships with numeracy. So people who had stronger preferences for numbers as opposed to words were more likely to say they were very interested in receiving 3 of the types of sequencing results. So variants related to preventable or treatable disease, medication response, and then the ancestry and physical variants. Self-reported numeracy ability was not predictive. It was the preferences that were predictive. So preferring numbers versus words. And as I said at the beginning, the clinical factors were actually not predictive. So I had these hypotheses that people who had a known mutation would have less interest in some of the different types of genome sequencing results, and that did not hold up in our study. And I'll also show you a little bit about a second analysis that was just published in Patient Education and Counseling by one of my students, Rich Albrechtsson. So we asked people, if you had a result returned, what information would you want to know about that result? And we asked them 14 different topics that are often returned when we return results. People answered on a scale from 1 to 4. They were not at all interested in that topic, or they all the way up to they were very interested and wanted a lot of information on the topic. So what we're showing you again is people who said 4, they wanted a lot of information about the topic. And again, what people were most interested in, and this is consistent with what others have shown, they were most interested in the health implications. So they wanted a lot of information about the implications for prevention or treatment, the effect of disease risk, the effect of the variant on disease risk for themselves or their family. Interestingly, though, they also wanted a lot of information about the certainty of the results. They did not want they had less interest, I should say, in some of the topics that we often return to people along with results. So there was less interest, for example, in how the gene worked in the body, the prevalence of the variant in the United States, and how sequencing was done was actually the information they wanted the least of. We created an information needs score of how many topics for which each participant said they wanted a lot of information. On average, that was 8 of the 14 topics. People said they wanted a lot of information. And then Rich Albrechtsson created a multivariable linear regression model, again, predicting information needs scores. So the direction of this is showing the people who wanted more information about a lot of different topics. And again, what we saw was that self-reported numeracy ability was not what was predictive here. It was preferences. So people who preferred to get information in terms of numbers rather than words were more likely to say they wanted a lot of information about more topics. Similarly, people who had higher knowledge about benefits wanted information about more topics, as well as people who had biological siblings. So people who reported their siblings were living were more likely to want a lot of information. Interestingly, actually, we're still trying to kind of figure out what this means. People who reported that their mother was living were less likely to say they wanted a lot of information about topics. So the third example that I'd like to show you is just to turn to some of our work that's more focused on health literacy as opposed to numeracy. I had the good fortune to work with Jennifer Hay and Marianne Berwick on their Sombra study, which was a randomized controlled trial. And in the trial, we were able to look at whether health literacy was related to people's cognitive and emotional responses to the variants for MC1R, which is a gene that relates to melanoma risk and has risk increasing variants that are pretty common in the population. This is just a little bit about Sombra, the trial, just to get a sense of the population, because this study had the advantage of being a more diverse population than we're able to do in a lot of, or have been able to do in a lot of genetics-focused studies. So patients were enrolled at the University of New Mexico. These were primary care patients who were enrolled in the primary care system, and all adult patients. They could be fluent in either English or Spanish. There were 600 who completed a baseline assessment and were randomized to either a waitlist control or the intervention group, which was where I'll be focusing, who received a personalized genetic testing invitation to MC1R testing via the internet. About half of the people, 43%, who were offered the MC1R testing, registered a decision on the website, so said they were interested or not in testing. And the vast majority of those actually were interested in testing. What I'll be presenting are data from the 2-week follow-up, looking at people's cognitive responses related to MC1R testing. This is the feedback that people received. We spent a good deal of time on using plain language guidelines and clear communication guidelines, as well as best practices for conveying numeric risk information. So these icon arrays, the little people diagrams that you see there, are often recommended for conveying risk information to the general public. The feedback that you're seeing on the left is for people who were at average risk of melanoma. The feedback on the right are for people who are at increased risk of melanoma. So just to highlight a few things, in addition to the icon arrays, we tried to clearly interpret the results. So for example, the orange box there on the increased risk results say your results show you have one or more risk types. So you have a higher risk of getting skin cancer, whether you have lighter or darker skin. We had a little bit of background about melanoma, a little bit of background about MC1R, but really tried to focus on their risk and the interpretation of that risk. And this was based on our prior work on the multiplex study, which was conducted at the National Human Genome Research Institute, and showed good recall and interpretation of this. Most of the participants who completed the 2-week follow-up were women. About 2/3 were non-Hispanic white, and about a third identified as Hispanic. Despite our best efforts to recruit people who were Spanish language, the vast majority of people had a preference for English language. You can see about 10% of people had a high school education or less. On average, they were 55, and they had fairly high subjective health literacy. So this is on a scale from 1 to 15. So they had an average of 14 out of 15. This is a little bit about how they responded to the feedback for MC1R. So this is their genetic test results and their responses to those results. We asked them on a scale from 1 to 5 how much of the results they read, and generally they said they read most or all of them. We asked them on a scale from 1 to 7 how clear and how believable they felt the results were, and they thought the results were very clear and very believable on average. They had low levels of confusion about the results. And when we asked them how often they thought about the results, the answer was really somewhat on average, a 3 on a scale from 1 to 7. So these are adjusted models looking at the effect of health literacy on each of these cognitive outcomes, controlling for education and risk level, as well as age and ethnicity. So what you can see here is that the relationship between health literacy and the cognitive outcomes was with confusion. So despite our best efforts, people who had lower levels of health literacy reported that they were more confused about their feedback. And that was regardless of whether they had increased risk or average risk results. Education was also related to how often they thought about their results. And people with a higher risk level were less likely to say the results were clear and were more likely to say that they were confused. We also saw an interaction between health literacy and their level of risk in impacting the outcome of how often they thought about their test results. And the direction of this association is that for people who were at average risk, having lower health literacy meant they were more likely to think about their results. They thought about their results more often. Whereas people with increased risk, which is the dotted line, the association was exactly the opposite. So people with lower health literacy were less likely to think about their results if they were at increased risk very often. So just to summarize, sorry about that, some of our findings from the health literacy and numeracy studies. So what our results have shown, and this is largely the SOMBRA study, is that despite our best efforts to create a plain language risk feedback, those with lower health literacy did report have higher confusion about their genetic test results. And we also think what the interaction is showing us is that health literacy may affect the extent to which people elaborate or think deeply on their genetic test results. And I think what our results are showing is that there's still a need for additional educational support for patients with limited health literacy. And then what we're seeing for numeracy is that people's preferences for numeric information, so people who like numbers essentially, may impact the type and amount of information that they want about genetics and genomics. And so this is showing us that there still is a need to develop feedback strategies for genetic risk that are appropriate for people who prefer words, verbal presentations, as opposed to numbers. So what I'd like to do in the last little bit here is just to talk about how we've carried this work on health literacy and numeracy forward into one of our larger clinical translational projects. So this is a study funded by the Cancer Moonshot Mechanism, which we call BRIDGE, Broadening the Reach, Impact, and Delivery of Genetic Services. I serve as one of the principal investigators together with my colleague Ophira Ginsberg at NYU. And the goals of BRIDGE are to identify unaffected primary care patients who meet current guidelines for evaluation for hereditary cancer. And we've done that using an algorithm that mines the family history information in patients' electronic health records. And that is done. I'll show you a little bit of the data on that. So what we're doing now is a randomized controlled trial comparing two different ways of delivering these cancer genetic services. An enhanced standard of care model, which is our control arm, and our intervention arm is what we call a patient-directed arm, where the genetic information is provided by an automated conversational agent or a chatbot. So in terms of our study design, as I said, AIM-1 is largely done. So we have identified patients who meet current guidelines for testing in both the University of Utah and NYU healthcare systems. Of patients in the appropriate age range, which is 25 to 60, we have identified actually more than 22,000 patients who meet current guidelines for genetic testing without collecting additional family history information. This is just based on family history information that is already in their medical record. So for the trial, we are randomizing about 3,000 of those patients between the two sites to get either enhanced standard of care or the intervention arm. And the control arm involves outreach by a genetic counseling assistant through the MyChart patient portal. So we're doing active outreach, which is really the enhancement in enhanced standard of care. But the rest of the procedures are all standard of care genetic counseling. So a pre-test visit as well as a return of results visit, both conducted by a genetic counselor. Our intervention arm, in contrast, we have again outreach by a genetic counselor, so they get a message through MyChart, but the message invites them to do a pre-test genetics education chat with the chatbot. And then the negative results are also returned by our chatbot. Positive and VUS findings are still returned by a genetic counselor. So the rationale for this aim is really, can we save the limited genetic counseling resources for the more intensive and interpretation heavy positive and VUS findings, and have some of the more standard genetics education delivered through a different type of technology. And then aim 3, which I won't really talk about, are 2 follow-up questionnaires that look at satisfaction with the different models, people's cognitive responses to the models, as well as their adherence to clinical recommendations. But what I wanted to highlight was some of how our thinking about health literacy has gone into our intervention model, which is the chatbot. So we are using what used to be Clear Genetics and is now Invitae platform, but we entirely scripted the chat for our own study. And that was for a few reasons. So one is the content was as close as possible to what our genetic counselors say in pretest education and return of negative results. But we also thought a lot about jargon. So when to use genetics and genomics jargon and define it, and when to try to do substitutions with more common language. We also used a technique in health literacy called layering information. So we thought about what core information should everybody receive. And then we gave a lot of options to see for people who wanted additional information that they could get it. So I'm not sure this is visible on the screen, but with words like positive and mutation, they're underlined. And the reason they're underlined is that patients can hover over them and get a plain language definition of each of these terms. One of the advantages as well for this type of technology is that it's interactive. So people can ask the platform questions, they can ask the chatbot questions. We programmed responses for about 250 questions, and natural language processing is utilized so that the computer can try to figure out what people are asking and give the appropriate response. And so far, actually, we have only had one question that couldn't be answered through a scripted answer, and so that was sent to the genetic counseling team. But this interaction is best practices in health literacy as well as interactive media learning in helping people recall and interpret information. And then this is just our first outcome, asking at the end of a pretest genetics chat to what extent they are interested in testing. And then we follow up and actually order that test through a genetics counselor, genetic counseling assistant, sorry. And a last piece of data, this is from the pilot of the chatbot that we did at the University of Utah. We reached out to 100 patients, 103 patients at 2 different clinics. About 30% started the chat, which is actually very similar to the 31% in the control arm who reached out to us to schedule a genetic counseling appointment. Almost everyone who started the chat completed it. And of the people who have gone through testing so far, we're still rolling out testing. We have identified 2 positives out of 26 people, 4 negatives, and a number of tests are still pending. So in terms of our ongoing research then with Bridge, we have a number of planned analyses where we're planning to look at the impact of health literacy and numeracy. So the primary outcome, at least of the second aim of the study, is looking at uptake of genetic counseling and testing for the 2 arms and comparing them. So we're planning to look at differences by rurality, race and ethnicity, as well as health literacy there. We'll be looking at the impact of health literacy as well as numeracy on people's cognitive, emotional, and decisional responses to the 2 arms. And then we're actually starting an analysis now of our pilot, looking at how people use the chatbot. So how interactive were they? How many questions did they ask? What topics did they request? And we'll be looking at the impact of health literacy there as well. So just to conclude, this was obviously the work of a lot of different people, not just me, too many actually to fit on one slide, so I have 2 slides of acknowledgements. I won't go through them all in the interest of time, but just to acknowledge my fantastic teams of collaborators for the scoping review, for our communication preferences study, and then my colleagues at the University of Utah, as well as NYU on the Bridge U01. And then the Sombra team, which was the randomized trial in New Mexico, which was collaborators from Memorial Sloan Kettering, the University of Mexico, Klein-Bundel, and then me at the University of Utah. And this work that I've presented was funded both by the National Cancer Institute as well as the National Human Genome Research Institute. So just to conclude with a view of Utah, as well as my contact information, and I would be happy to take questions or talk to anybody afterwards.
Great, thank you so much, Kim. That was a terrific talk. While people are thinking about their questions, and please, if you have a question, just type it into the chat box at the bottom. Let me start off if I can. I was struck by one of your slides, which showed that in one of the studies you reported, people on average asked for a lot of information in 8 different areas. That got me wondering what you know, whether you have data or what you know from the literature with regard to how much information people can actually assimilate. We're working with a research group that's part of an NHGRI consortium right now, which is struggling with this question of, you know, how much information is given back about how many different disorders, since there will be a variety of, in this case, polygenic risk scores that are being assessed, and how much additional information, contextual information, is provided in addition to the genetic information itself. How much can people absorb? How much can they tolerate?
Yeah, such a good question. And actually one I spend a good deal of time thinking about. So my health literacy background tells me less is more. That is exactly the opposite of what we usually do in genetics, where we provide a lot of context, a lot of additional results, multiple types of results. And I think there are a couple of different ways to deal with this. And I should say, so the research tells us people remember somewhere between 5 and 7 ideas. And that's actually a little bit less for people with limited health literacy, particularly, where it's more like 3 to 4 main ideas. So if you give people 25 ideas, what they do is remember some subset of those ideas. But there are ways to deal with giving people a lot of information. So one is to do this sort of layering approach where you decide on a core information and then give people options to get more information if they want it. Or to try to do what health literacy people call chunking the information. So organize it in some way that makes logical sense to patients and that actually improves recall. Yeah, it's such a good question. I think we are really heading toward a problem of information overload is what the data is starting to show us, that we are just giving way too much information, and what's happening is people don't really remember any of it if you give them a ton of information.
Great, thanks. So we're starting to get some questions in. Matt Lebowitz here at Columbia asks, could you say a little bit more about what the difference is between genetic knowledge and genetic literacy?
Yeah, it's a good question. And I should say this is how I think of it, because other people think of it as essentially the same. But because of my background in health literacy, I think of literacy as a broader construct. So it incorporates knowledge, but it also has the skills domains. So it is knowledge, but it's also processing, as well as decision-making, and to some extent, accessing information. So I think of literacy, and others do as well, in terms of having skills and knowledge domains, whereas genetic knowledge I think of as just knowledge. And I think it's been useful to think about it that way, because I think we've overlooked some of the skills domains in this area. So how people are processing the information particularly, And I think using the broader definition has helped to encourage some of that work.
Great. Maya Sabatello, who's another of our colleagues here at Columbia, said the following: finding that those whose mother is still alive wanted less information is interesting. That seems to work with the literature on genderization of genomic medicine. Have you looked into whether there's an association between the gender of participants and responses to this item, as well as whether the gender of remaining siblings may be associated with these responses? And I think part of what Maya is referring to with regard to the literature is literature that suggests that in a family, the woman in the family, the wife, the mother, tends to be the one who takes responsibility, as it were, for the family's genetic history, genetic information, acquiring new information, as opposed to the father or husband in the family.
Yeah, that's a great question that we haven't looked at it in much detail in that particular data. I have looked at it in some of the more family health history work that I've done. And I agree. I think what we're seeing is probably a combination of gender and generation there. So that people who don't see themselves as the oldest generation kind of don't want to worry their mother, but also kind of think it's the matriarch role to have that collection of family history. I haven't thought of looking, actually, it's a great comment on the gender of the siblings to see if that makes a difference. My guess would be that it would, based on our family communication studies. People consistently are more likely to talk with their female relatives in any given role as opposed to their male relatives. It's a great suggestion.
Camilla Rising asks, do you work with people that have very high risk, such as people with Li-Fraumeni syndrome? Do you think or have evidence that they have unique needs in the context of genetic literacy and or unique challenges related to communicating information back to family members?
Yeah, so I haven't worked with Li-Fraumeni families, although we do have a cohort here at the University of Utah. I have worked with the Lynch syndrome families that we have. So we have a large cohort of Lynch syndrome patients who have varying degrees of risk depending on the mutation, but some of them have fairly high risks. And I think what we're seeing is that they have stronger information needs than people who receive genetic susceptibility feedback, where there's a lesser degree of risk involved. So our Lynch syndrome families are what I would call high information seekers. They want a lot of information. They are also coming up against a situation of having providers who know less about Lynch syndrome. So they themselves feel like they have to maintain knowledge about a lot of these issues. That I haven't actually ever been able to compare them in the same study, but I think that would be a really interesting question to look at the degree to which people need information depending on their level of risk. But at least anecdotally, comparing different studies, we are seeing stronger information needs associated with a higher degree of risk, and I would imagine even more with Li-Fraumeni.
Jada Hamilton asks, do you have a preferred genetic or genomic literacy measure? She says, I've personally struggled with this and wonder to what extent the measurement issues are limiting the associated research base.
Yes, Jada, you and I are on the same page. So I keep thinking that, yes, one of the issues is that lots of people call different things, and it gets back to the question that was asked at the beginning about the definition between genetic knowledge and genetic literacy. So some of the studies have looked at really genetic knowledge, but called it genetic literacy. I have been using Jillian Hooker's genetic literacy measure, which is, it has some skills domains, but I think there's still some limitations to really all of our existing measures. And I do think partly what we're seeing is that people are using so many different measures to measure so many different outcomes that there's just really no consistency in this literature and what we're seeing in terms of associations. And I do think, in my spare time, one of my goals is to do some measurement work in this area and really try to think through from the conceptualization of the construct, what would be the best way to measure it?
So there are a couple more questions, but we're not short of questions, but we are short of time. So I would, since Kim was kind enough to put her email address up on the screen, I would encourage those of you who ask the questions we haven't had time to get to write her directly, and perhaps she'd be good enough to answer for you. And this talk, I should say, has been recorded and will be added to our series on the web, and you can find that through our website at braingenethics.org. Kim, let me just say there are several comments in the chat box just thanking you for your work and this presentation, and let me echo that. It was a great talk, and it reports on a really important body of work. So thank you so much for joining us today. Everybody else, I look forward to seeing you next month and on subsequent presentations. Bye.